everyone. My name is Jesse Chason with Lisa Blanchard as the host of Airing Addiction.
I share often my journey started on this campus. Got sober as a client here, just like you.
I really do see phenomenal change.
Always hope. I've seen situations that on the surface look impossible, become possible.
Doing this podcast is to share those recovery stories, be honest about what the challenges are and have some real conversations, but kind of share that out on the airwaves.
Welcome everybody to August edition of Airing Addiction. If you're listening live or on Facebook or later today or somewhere around the time that we are recording this, we are focused on overdose awareness. For this episode, we have a very educational, engaging, informational panel about just that and how Spectrum Health Systems is combating overdose and some of the things that we are doing to help patients really receive the care that they need. So good morning, Lisa. Who do we have here today?
Good morning, Jesse. Thanks so much for that. So I'm really excited. I asked this panel to join us today because it's something that gets me very, very excited. And I thought this last week of August, during Overdose Awareness Month week and coming up on Overdose Awareness Day, was a really great opportunity to talk about what we can do specific to reducing overdose, right? The risks out there are extremely high. They've been higher than I've ever seen in the 25 years that I have been doing this work. And, we have to change how we do things in order to change the outcomes that we're getting, right? There's lots of reasons why overdose is so high because of fentanyl. And people, you'd have to kind of be under a rock to know that. And if you're listening to a podcast on addiction, I'm pretty sure you're pretty well aware of how high risk it is out there. But what we need to do, what can we do, is to shift how we support people. So that, as we take a pause this month, this week, at the end of this week for Overdose Awareness Day, to recognize and honor those that we've lost, we can also at the same time talk about how can this not happen again, right? And turn our pain into purpose. So with that, I would love to introduce our panel today. So we have Heidi DiRoberto. She's a licensed mental health counselor. She's our regional executive director in our outpatient division. She oversees our largest OTP, as well as the mobile unit we're here to talk about today. Has done lots of great work around access, providing rapid access to buprenorphine in our hub and spoke program, delivering medications to skilled nursing facilities, and specific to overdose, really operationalizing the delivery of Naloxone, Narcan to our OTPs. So this is something very near and dear to Heidi. So we're happy to have her here. And we also have the nursing perspective. So we have Amanda Bouchard, who's a certified addictions nurse and is our outpatient director of nursing and really had a huge part in opening this mobile unit. And so we're really looking forward to having Amanda on and talk about, from that nursing perspective, how can we do things differently to provide support and provide medications to change the outcomes. And we also have Mariana Valera, who's bachelor's level, but is an intern with us for her master's program at Assumption. Shout out to Assumption here. And we're really excited to have her. Her role with us right now, beyond intern, is as a recovery support navigator. And so that role we'll talk a lot more about. I'd love to hear about how that's working on the mobile unit. But it's really helping individuals access the supports that they need, the wraparound care that they need to access recovery, access treatment, and support themselves. So with that, I'm going to probably turn it over to Heidi to kick us off. And so, Heidi, tell us a little bit about why did Spectrum decide a solution to some of the challenges we're seeing might be mobile delivery of medications?
Great question. And sometimes we say it sounded like a good idea at the time. and it has been. Actually, we invite people to go out there because certainly when I'm on the mobile unit, it reminds me of why I came into this field, because it's really just helping people where they're at. So in July 2021, the DEA, released, one of the ways that they wanted to continue to, demonstrate their commitment to expanding medication for opioid use disorder was to, allow for mobile units in the community to, meet people where they're at. And we, my predecessor, Tracy DeRusso, was really excited about this, and really pushed us to consider it. And then Dr. Castile, who's the Commissioner of Health and Human Services for the Department of Health, really challenged us to think about, could this be a way that we could help get medication to some of the folks in our community who are struggling with housing and other social determinants of health. And so we began our journey. And during COVID, this was a tough journey to take on, because we couldn't even find a company to build out our mobile unit. So we really just did things, from the nuts and bolts. We purchased a new mobile unit, and we had it completely refabricated to meet our needs. But the goal, so that's the how, but the goal really was, our brick and mortar programs had a lot of patients. We knew we were serving a lot of people in our community, but we also knew that there were a lot of people who were coming into our programs from, being referred by the community outreach workers who could get them to us for a couple of days, and then they would stop coming to us, whether they couldn't get transportation. There a plethora of reasons why they couldn't make it to us. And when you don't have a car and you don't have a home, traveling more than 4 blocks is a hardship. And so we knew we were having people, travel across the entire city to come and see us. So that definitely motivated us to give this a shot.
So, Amanda, tell me a little bit about what it was like. I know you were there in the early days on the first rides of the van. Tell me about how this is different from providing medications in a brick and mortar opioid treatment program. And you might hear me say OTP for our listening audience. If you don't know what that means, I mean opioid treatment program, which is both federal and state licensed program that is able to provide methadone treatment as well as other medications for opioid use disorder. So Amanda, tell me what's different about this van.
Yeah, so this van, is really special. It's really special to us who were involved in starting it. It's really special to the staff that now manage the day-to-day of it, and really special to the patients that it serves. Like Heidi said, getting to our brick and mortars is really difficult when you have all of these different factors working against you in your life. But, as the nursing staff and being able to go on there, we try to keep it as similar as we can to an OTP so that you're getting that same experience. But we are able to diversify and modify this treatment in a way that, as Heidi said, we are meeting people where we're at, but we're doing it so that we can, grow where they're at. We don't want them to stay where they're at. So while we'll meet you there, we want to be able to get you into the brick and mortars, get you into treatment and a stable routine where you are able to meet this level of care, all while, again, individualizing it and making it what you need it to be in the moment. And how can we retain you in treatment? And so, I think as nursing, we've seen a dramatic retention in patients who previously, we used to see drop out of treatment at the brick and mortars because of transportation, because of job schedules, because of housing. All of those factors play such a big part in this. And it takes you into a different perspective. I encourage anyone who, has maybe been in this work for a while to try something new and to go out into the community. It is different in that aspect. It just kind of gives you the perspective of, wow, I'm in my patient space. I'm in their world now. I'm seeing the struggles, and you start to understand where your patients are in treatment. We all have ideas of where we would like people to be, but they're not necessarily our patients' goals. And so I think this aspect of care lets you see all of that and really gives you that good insight into who you are treating and what you're dealing with, so that you can get that overall care.
I love that perspective so much. It's very tied to a lot of the work we've been doing as an organization to shift our services, because it's really, instead of this kind of old school perspective of recovery that when you're ready, you'll find us. When you're ready, you will show up and you'll be able to do it, and you'll navigate the transportation and you'll figure it out because you want it that bad. Or when you hit rock bottom, it will be enough for you to do the work, to work on your recovery. And it's really not a recognition of the chronic disease of addiction, right? How challenging that is. It is a chronic brain disease, right? We don't say that to people with diabetes, right? Like, when you're ready, you'll just change your diet and you'll be fine. We provide life-saving medication to keep people around while they slowly work on the lifestyle changes that they're willing to, right? Whichever ones they're willing to. Like, that's our medical perspective, but it's not the perspective we have given to addiction for so long. And by going to where people are at and removing barriers in providing life-saving medication that has a lot more flexibilities now, right, than it did, but it still has some regulatory challenges to it. We're really shifting that narrative that you deserve a medication to treat your condition, right? Regardless of what else is getting in your way. Right? We don't ask anybody else to show up at a program on a daily basis and receive their medication in person in any other way. And this allows us to bring it directly to folks. And I really, really loved your thoughts about, doing community-based work is doing the work where you're in their world, right? Instead of requiring that they enter your world, right? We're putting ourselves as a support and a care option in their world, right? And can see it really, really differently. That just really struck me, Amanda.
I'm glad. It strikes me every time I'm on the mobile unit. And I do try to go as often as I can, because it really helps keep you grounded as someone, in a substance use disorder work. And you're connecting on that ground level, literally,
Yeah.
to provide that care, and just, we're getting out there. We're doing the hard things, but our patients are doing harder things, and we just need to be able to recognize that. And I think it's, being out in the community, then you're, advertising your services to people that might not know what options they have. When you're going through active addiction, you're just thinking about your basic needs, and you're not, the counseling and the lifestyle changes and all these things are absolutely necessary to recovery, right? But and sustaining recovery, but your basic needs is what needs to come first. And I think that, the medication piece of this is what's going to help some of that. And, we know that methadone works the best if you take it every day. And if you don't take it every day, you're not getting there. You might still feel sick. You're not going to engage socially and high level things that we need to do. So, just bringing this has, again, helped retain people in the community. just to get their medication. You know, we had one patient early on who was like, you know, one of our first patients that we helped on the mobile unit, and he went from missing, you know, 50 something days in a matter of months to 1 day in maybe 6 months.
Yeah.
And even if, you know, I've found, and I wish I had a statistic to give you, but even if, you know, someone does drop out, their return to treatment time is that much faster. They're able to find us. They're finding us in the community a lot easier than they're finding us at our, you know, our brick and mortar bases. So even if they are gone, they come back quick. We have eyes on folks that we're watching, and we're trying to help.
For folks who work in any kind of medical capacity or have ever had challenges with themselves or loved ones adhering to a protocol or a medication, when can you see change, like 50 missed medication days in a matter of months to 1? Like, when do you see that kind of change? There's nothing that really shifts it that much. So on that perspective of getting kind of basic needs met, and that being really the priority, right? For the clinicians in the room, right? That's Abraham Maslow's hierarchy of needs. The very bottom is like, do you have housing? Do you have food? Do you have like the basic needs? I think that's a good, segue to ask Mariana about what are the kinds of things that the individuals you're interacting with as a recovery support navigator on the mobile unit, what do people need? What are their challenges?
Yeah, that's a good question. I think it's like safe to say a majority of the patients we deal with on the mobile unit are at a shelter or are homeless. That's not everybody, but it's a good chunk of our patients. So that's like obviously problem number one for them, at least. And it's tough, like seeing them, like Amanda's kind of saying, like we're seeing them in their world. We're seeing them interact with these people. And I think getting a better understanding too of like how they continue these cycles, or why they prefer to stay on the streets in a tent versus like a shelter. Like we're going to these shelters, we're going to like some of these places they prefer to hang out at. So it's a little different and it gives you that perspective. But I would say the biggest thing is homelessness, and trying to encourage like going inpatient and where can we start. And we're doing a lot of like trying to navigate that higher level of care for them, or even just starting that discussion with them. If they're not ready today, they know we're there. And I think that's a big part of it. And really just like encouraging like some like starting that stability, like whether that's, you know, coming every day, let's get your dose stable, and to a point where you're feeling comfortable to maybe target some of these other things, because it's tough to target things when you're in withdrawal, and not able to focus on other elements that we may see as important. They're not ready for that yet. So I think, you know, the mobile unit has been able to allow at least them to daily medicate. And I, like Amanda's really saying, like I have my own patient that I've seen come in and out of a brick and mortar at Lincoln Street for the years I've been here. Now I've seen them not drop out of treatment at all since starting the mobile unit. Like they'll miss a day, but it's not a week where they're dropping out. So it's like a really big change for people who have that need and are like don't have transportation. You know, we can say use a bus, but that's not as easy for some of these people who wake up in a tent and don't even know what time it is. So I think things like that are like the biggest thing we are seeing. And honestly, it's a lot of like check-in type of things. Like we work really closely like with our program safety guides and obviously nursing on that mobile unit. So if we see something one day, we'll make sure to check in the next day, even if they don't ask to check in, like, hey, we noticed this is going on. And I think it makes all the difference to be able to, for them to know that we're there if they need to check in and need to talk about something or have a conflict or risk that we want to check in about. But we also like develop this sense of like community with them. I think being in the community where they trust us enough to, even if they don't stop and be like, I need help today, it's, hi, Mariana, like my day's actually going really good. I did this today. Like I managed to go here today. And they'll do that with all of us, the nurse, the program safety guide, they really just, I think we've been able to like develop the safety net with them, where they trust us enough to kind of just update us and check in. And if something's going good or bad, they're willing to look for that support. So it's a different atmosphere, but in such a good way.
That's great, Mariana. I heard so much great stuff there, and I heard you say, really boots on the ground, seeing through our patients' eyes, right? Because as a clinician, let's face it, we can write like a great treatment plan and hit all the goals and make it look really good. But like if we're focused over here on problems X, Y, and Z, and the patient's focused over here on problems A, B, and C, like the treatment plan's just missing the mark, right? It's not doing what it needs to do. And I heard you say, just the presence of Spectrum, in the community is developing this sense of trust and this sense of, comfortability with, maybe one day it's a daily check-in, and then the next day it's, actually, I've been thinking about this treatment plan goal, or, going inpatient. I mean, I know that's something that I've had personal experience with patients, that go from being medicated in the community all the way into one of our higher levels of care. And I'll just throw this out to the panel to talk about that process a little bit, or anything that you've observed as the people that are doing that literal life-saving work in the community. How has that process been for you, for the patients, and that experience?
Just wanted to start with I think Amanda and Mariana really touched on this, but this is really low barrier access. So really trying to meet people where they're at. So this could be the clinician talking to somebody while they wait in line for their medication to come up with treatment goals, because the patient cannot sit in the clinical room. This may mean, that like a conversation starts today, that's going to be finished in 3 days from now because the patient can't tolerate it. I think that's these folks have not been successful in our traditional brick and mortars because the structure of coming in and making an appointment just hasn't worked for them. And I think that's what's so wonderful about the mobile unit is the staff really recognize that, and they're just meeting the needs, whatever the needs are that day, and really being creative in how they're developing treatment plan goals and how they're working on those objectives with the patient. And it takes a special person to work on that unit. But the results are just amazing. People are coming back every day. They're planting seeds. People are seeing their gains. And that's what's motivating people to come back. And as we know, even if, and the staff are doing so much more than this, but even if the patients are just getting their medication every day, we're reducing their risk of a fatal outcome and overdose by 50%, which is just amazing. And, so like, when we think about the city of Worcester, this Commonwealth of Massachusetts, and the problem that we have with opioid use disorder, this is really addressing that need.
Right. Directly targeting that risk of overdose with community-based work. And so, that was one of the things that Mariana said that really struck me, right? Is that, yes, of course, sometimes we will, and whenever somebody's willing to increase level of care and increase their supports, our answer is yes, right? Like, let me help you do that. But there's a lot of people who are just not willing or able to go to an inpatient program. And that might not be what they need today, right? Like that. So how you phrased it, Mariana, I really appreciate it, is building stability in the community, right? Where they are at. And so what can we do today? We can help you be stable in exactly the environment that you're in while we work on how we can improve that, right? And that might be staying in the community and continuing on medication and starting to work on those goals, or it may be accessing a higher level of care and going to treatment beds. Like, we need both solutions, but the answer isn't always a bed, because that's not always what the person is willing or able to do. And there's not always a bed available. That's part of the challenge, but we can usually make that happen, right? Having a full continuum of care. So I don't know that that's our biggest challenge. Our biggest challenge is the person being willing to, or wanting to, or needing a treatment bed.
Well, and so for a good portion of the folks that we're treating that are unhoused, everything that they have is in those, you know, in their encampment, right? So like every piece of clothing, memory, picture, you name it. So sometimes just even the thought of leaving that encampment can be difficult, because who's going to watch their stuff and make sure that their stuff is okay? And that's why, you know, okay, so can we build stability, like Mariana was saying, by let's stabilize your opioid use disorder, and then, you know, work with our community partners like SMOC to try to help with housing, you know, and that's where, you know, Dr. Castile really motivated me was, you know, we're putting a lot of people into housing placements who are actively using, and it's not successful. And so could we stabilize folks before we place them? And this is just one way that we're able to contribute to that.
And the other thing that strikes me, and I've heard it said multiple times already, is because we're here, because we're embedded in the community, it's creating a sense of safety and building trust, right? So again, sorry to keep bringing it back to Abraham Maslow's pyramid of needs for the clinicians in the room, but the right after your basic needs is safety, right? And we can't do anything or work on anything without safety, and trust in the community is probably one of the things that gets in our way as treatment providers for folks who do not walk in our doors or do not stay in our brick and mortar locations, right? Because we know that we've done podcasts on trauma here, a couple of them, right? So we know that there is a significant, if not all, incidents of trauma histories with individuals with substance use disorder, particularly with opioid use disorder. And that leads to a lot of challenges with trusting that others will be there for you to support you. And so our consistency of being there in the van and seeing the same people and building that trust where their community is, I'm wondering if that's really making a big impact for folks.
Yeah, I think we see that a ton. You have your most vulnerable populations coming to this mobile unit. And let's just use Lincoln Street because it's such a great example of, 12, 13, 1,400 people that are enrolled in that program. While that's wonderful, it is so big, there's so many people to help. But what does not come with Lincoln Street is that very tight, tiny community of people who are there every day. You might go and you might see a different person each time you walk in. And while you get great care and they get to know you, going on the mobile unit, if you're if you have a fear of trusting folks with such sensitive information, right, where this is so stigmatized, and you're walking into a place and you have to retell your story to 20 people or see 20 different faces, it is challenging. I feel like the mobile unit is very welcoming because it's a very small rotation of the same people. We have all disciplines there. We have clinical, we have recovery support navigator, we have nursing, we have, nurse practitioner or medical director support. We have program safety guides and drivers and recovery coaches, which is huge towards that population. We have this group and they see the same faces day in and day out, and they are not only just now willing to talk to you about their substance use disorder, but they're willing to talk to you about the wounds they got or the legal trouble they're in, or where they're having trouble finding food. And you can really take that whole picture of treatment, right? Like, it's not just the medication. It's not just these little things that, personally, as a nurse, when I first started in this field, you only really kind of saw what you did and you didn't get to see that whole person's story. I know it's not like this, but sometimes it can feel or look like this, that it's a factory line, right? Like we're getting you in and getting you out. And so, trying to combat that and really personalize goals and individualize treatment for patients, but also the staff to help them connect to really be able to do that. Because if you don't see it, you're just kind of blind or ignorant to everything else that's going on. And so they really come together and work as a team to make sure that everyone, in every discipline knows what's going on with these patients, which I think is just very special to this project.
That's a great point you bring up, Amanda, just because the nature of what we're doing out there in the community, what you are all doing out in the community, people see the same faces every day and they can see the consistency. And as it's been said here already, with substance abuse disorder and trauma and lack of trust, and if you're living on the street or living in an encampment, you are constantly on edge for not trusting, or maybe things aren't what they seem. And it almost seems too good to be true, right? You'll drive to where I am, or a short distance away so I can walk there, and then people see the van, and then they start seeing it every day at the same time, and builds that consistency and that trust. That's such a great point that you made about that.
And we become part of that community, right? Instead of just serving the community, we become actually part of the fabric of that community.
Absolutely. Yeah.
So what else? Like, what would you say to someone who, said like, this doesn't seem like it's worth it, or, folks should be able to come to you? Like, what kinds of impacts have you seen, on the van?
Sure. Well, in 13 months, we treated 782 unduplicated patients. So that's 782 individuals in the city of Worcester who, were not receiving treatment, came to the van, which is wonderful. The average daily census is about 100, 135 people a day. That is bigger than two of our smallest brick and mortar programs.
We actually medicated 151 patients just yesterday.
Yeah. So, right. Every day, like that we go to check these numbers, the numbers increase, which I just think speaks volumes to the need. And the van is providing more than just medication. So this population is more susceptible to xylazine wounds. They're treating them. They're accepting fentanyl test. They're accepting Narcan from the team. Recently, we've collaborated with Brandeis University and APW, and we're now participating in drug testing to just help the community know what is in the substances out there. So we had a couple of people volunteer to, either have their baggies tested or what they had been using tested, so we can contribute to the information in the state and in the city. And I think those types of things don't traditionally happen willingly in our brick and mortars unless we set up tables that we're like, here, this is what we're doing today. And, of course we have patients who will participate, but I just think that spirit on the mobile unit is different.
Yeah, because you built that trust, right? So there's no like, well, what are you doing with this information? Am I going to get in trouble? Like when you say this is just to help you know what's in your supply, and it helps the community know what the risks are. Mm-hmm. They're like, they take it at face value because they trust you.
Mm-hmm. Yeah.
And then Spectrum has partnered with the Department of Public Health, and we're an affiliate of the community Naloxone program. And so all of our outpatient sites are able to get, free supply of Narcan for our patients, which, they're really accepting of. I think our latest update, this started in about May of 2022. And I think they've distributed throughout the state, not just Spectrum, over 50,000 doses of Narcan, which have been used to reverse a reported 1,200 overdoses. We know that number is incredibly low as a report, because most of our patients take it and they ask for more. And so we know that they are using it, but they're not necessarily just coming out and telling us, yes, we used it, for ourselves or for a loved one or something like that. And so we're engaging in that overdose prevention beyond even our own patients, especially using the mobile unit. These are our highest risk patients. And they'll have a friend walk by with them at the food pantry who is not interested in treatment and can still kind of use those resources. Well, maybe we talk to them and try to engage them. We did also start very early on admissions right on the mobile unit, so that they didn't even have to go to a brick and mortar to be admitted, because even just that one day to get to us to be able to start and then transition to the mobile unit was too much. And so we really successfully admit anywhere, early numbers was up to 10 patients a day. And now more around 2 to 4 patients every time we have admissions on that mobile unit. And it's, referrals from just the people who are already in the area accessing other services like the food pantry or the showers at the church or the shelters that we're at. And so, that's been a huge part of some of these numbers and interactions. And some people have now only ever known the mobile unit as Spectrum. Like they've never even stepped inside a brick and mortar, because when they haven't been able to, but they've never had to, because we've been able to bring all of our services to them.
And that's the people that we would never have seen, right? Like we never would have connected with them. And so, I'm just reflecting on, for listeners of the podcast, Recovery Month is next month. We tend to go big during that month and do weekly podcasts. And we spend an awful lot of time throughout all of these past 4 years that I have been co-hosting this podcast on talking about recovery, right? And talking about that impact of recovery, hearing recovery stories. What does recovery look like? Talking about that hope. But if we lose someone, we never get that opportunity, right, to move towards recovery. And every single person that you're interacting with in the community deserves that chance at recovery. And so when you were talking about the Narcan distribution and testing of substances and some really fantastic harm reduction strategies, those are all really focused on keeping people safe while they work on considering recovery, trying recovery, testing it out, like staying safe, staying alive in that time frame. And so that is really inherent in why I wanted to hear from you all today, as we look at, overdose awareness, right? That this kind of work is what is really needed to reduce overdose in our communities, because every time someone uses, right, this is the thing that has really struck me over the years, right? There's always been risk of overdose with opioids, right? It causes respiratory depression when added to other substances, but the risk is so much higher now with fentanyl and how strong the substances are in our communities that literally every single use could result in overdose, very likely to result in overdose. And so every time we can disrupt that, right, by providing a life-saving medication, every time we disrupt that by supporting someone with Narcan to reverse overdose, is another day that person has.
Yeah. and an opportunity for us to, help increase motivation. Like it's not, I recognize that, we can't wait for people to be ready, like that old thinking, right? Like part of our job of being out in the community is to really try to influence motivation and, getting people to think about change and consider change. And, that it doesn't have to look a certain way, that, small changes, lead to big gains, and really celebrating that for people.
Yeah, celebrating that for all the people, all 782 of them, in just over a year. So, I mean, that just screams to me that there's such a great need. And, I forget who said it, because there's just been so many great points on this panel, but, planting seeds, that's a lot of seeds planted. And that's a lot of change and motivation, maybe incremental at first and maybe small at first, or maybe not even noticeable, but, over the course of, again, now in 13 months, that's a lot of moving the statistics into a positive. So that's
Jesse,
awesome.
what you just said really it ties perfectly into what I wanted to say next. You talked about planting seeds, and one of the things I wanted to circle back to is one of the first things that Amanda said, and that we are helping people grow from where they are, right? And that is, I think, exactly what we need to celebrate, right? We are planting seeds, but not just planting them. We're sowing them, and we're watering them, and we are encouraging growth from where that person is to be where they might be tomorrow, next week, next month, next year. And that's just so fantastic. So as we get ready to, to wrap up this podcast, is there anything that you wanted to say today that we didn't prompt, we didn't ask for, or something that's really important to you about this work, or, a case you want to highlight? Anything that we missed?
I think we kind of touched on this, but I do want to just emphasize how much having a recovery coach on our mobile unit has really just changed the game for us. Shout out Jamal. He's gonna not like me for saying his name, but he's just so wonderful, and we're so grateful to have it's such a change, right? Lincoln Street, he works at Lincoln Street too, but the mobile unit, with how high risk they are, their needs, and how we've kind of said building that trust is so important. Clinically, it's a whole different world to have a recovery coach implemented. They can do things we can't really do, and have that perspective that we may not have or disclose with them. So it's just so powerful to see those interactions, and see his work, and have them develop that trust with him. So I'm so grateful to have that implemented on the mobile unit for our patients, and I can already tell they're really excited to have a recovery coach even at Lincoln Street. But I just know the need is so important on the mobile unit. So I just wanted to do a little shout out for that.
Awesome. So glad you did, Mariano.
Absolutely. And not just for our own recovery coach that's on the unit, but I really feel like the mobile unit is a hub for the city outreach workers and other recovery coaches that are working in the community, Open Sky, and many other organizations will send their recovery coaches to places where we're at, because there are people there that need services. So, often I'll stop by and I'll see a handful of people that I know that are working in the community, and they're just trying to very similarly do the same thing, just meet people where they're at, check in on them, see what their needs are. And so that's a pretty awesome thing to witness.
So while we're kind of the first, right, I know as an organization, we hope to grow and have more mobile units to do this kind of rewarding work in other communities. So I encourage folks to advocate for that. But specific to the one we have in Worcester, where can anybody who's listening or share with their loved one, where can we find you?
You can find us. Currently, we have 3 different locations that we are at on a consistent schedule 7 days a week. So from 6 a.m. to 7:30 a.m., they are at the Smock Shelter on 25 Queen Street. And then from 8 a.m. to 10 a.m., they are over at St. John's Church on Temple Street. And then 11 to 12:30, they are over at our soon-to-be open brick and mortar program, already getting people to where they need to go, right? At 1023 Main Street in Worcester. And so, we'll transition those folks maybe once we open that program, and then hopefully we can get some more stops and more places to outreach folks.
The next time you have us on, we'll let you know where we're going to be. But we're having, active, positive conversations with leadership within the city who are supportive of the work that we're doing to find, a third and fourth stop once we open 1023 Main Street.
I love it.
Who knows? Maybe we'll have a fleet of mobile units, right?
Yeah.
Driving around communities.
Yeah.
Well, thank you everybody for sharing some of your time today with us and talking about just the awesome, amazing work that you all are doing out there in the community. This has been such a pleasure personally, professionally, just to hear the different ways that we are all as an agency trying to help as many people as possible.
And thank you all for coming. I just want to share my gratitude for all of you and your entire team and the work that you are doing to support the community.
Thank you. Thanks for having us.
Thanks so much.
Our
All right,
pleasure.
that's our episode of Airing Addiction. Keep an ear out. We have some really exciting episodes planned for Recovery Month following the Recovery Month themes that are national and out there. In fact, one of the themes that came up very consistently in this podcast is housing, and we're hoping to have a panel on housing, I believe, during the second week of Recovery Month. So much more to come. Thanks, everybody, for listening.
Awesome.
Like, subscribe, all the things.
Thanks, everybody. Bye-bye.
Bye.